And so today we have a very interesting topic. We're gonna talk about mood disorders and psychotic disorders. But before we go there, I want to ask you if you had an opportunity to watch the anxiety disorder class and also the assessment class, and if you have any thoughts, questions about that.
No questions on my end.
No? Okay. What about you, Ashley? Did you were able to watch those classes, the recorded classes for anxiety and assessment?
Yes, I watched some of them.
Okay. Any doubts so far?
No, it's just a lot of information, so it's just trying to really like grasp my head around like the concepts and what you can and can't do. So it's just a lot of information.
Okay, okay, sounds good. What about you, Dara? Did you had a chance to watch those yet or not?
Oh, there I go. I couldn't unmute myself earlier. I haven't finished watching them. I began it, but I just haven't had time yet this week. But I'm going to sit down and watch it this weekend. But so far, no questions.
Okay, okay. So I hope that all of you give yourself time to watch those because those are very important topics. And I hope that I'm going to be able from now on to handle everything during the time of our classes so you don't have to do extra work going and watch those videos, okay? So having said that, I'm going to share my screen with you so you can watch the presentation that I have for you. Today we're going to talk about, I think there's someone that I don't know trying to come into the class. I don't know who's that person, so I'm going to remove that person. Did I told you that the other day I had a hacker in a class with my undergrad students? It's a very big group. It's 62 students. And suddenly I had hackers in the class and they start yelling, Mario Guzman owes me money. And all the students were like, what's going on? And I was like, wait, what? No, I don't know money anyone. So anyone. So someone was trying to come into the class again. All right. So we're going to talk about depression, guys. And what I want you to do is that before we start talking about depression, I want you to engage in an activity that is going to be very useful for you and very useful for your future clients as well. So let me go to that. Where is it? It's here. Okay. So I'm going to share this with you, this link, because I want you to go to that page and I want you to, what? Okay, let me see what's going on here. Copy. No, I don't know what's going on because I was able to click before. This is really weird. Okay, so why is doing this? Okay, I know what am I gonna do. So sorry for that, guys. No. Okay, it's here. So I apologize for that. And I'm going to share this page with you. I already have shared this before, but I'm going to do it through the chat. And I'm going to guide you. So please go and click there. Okay. And what you're gonna see is the online assessment measures from the American Psychiatric Association, okay? And in this webpage, you're gonna find a bunch of instruments, scales that you can use to assess your clients. But the best way to learn how to assess our clients is assessing ourselves. So the first thing that you're gonna see is that it says level 1 cross-cutting symptoms measures. This is when you are giving a general scale to try to identify specific symptoms. For example, you don't know what type of symptoms your client has. You can provide one of these and it's gonna help you to identify what type of disorder is likely to have your client, okay? Once that you have that in mind, or even if you decide not to apply one of these because you have good information and you think that your client has, for example, depression, that's what we're gonna see today, then you can go to level 2 cross-cutting symptoms measures, okay? And it is divided by age. So these are for adults, these are for children aged to 17, children's 11 to 17. And if you go there, you're gonna see this one, depression adult, promise emotional distress, depression short form. And what I want you to do is click there and it's gonna download automatically and then you're gonna have to open it. Oh, I'm not sharing my screen with you, right? I thought that I was sharing my screen with you. I'm so sorry, guys.
Dr.
So,
Guzman,
yes.
it was Michael who was trying to get back in.
Oh, really?
Yes.
Can you tell him if he can try to do it again?
Sure.
Well, that was embarrassing. Okay. Please tell him to try to do it.
Who did it look like it was?
It was like very weird, like only letters and numbers with no meaning at all. And yeah, it was not his name. So, okay. So what I was telling you is go to the page that I shared with you, this one, and you will see in the first section the level cross-cutting symptoms measures, and then the cross-cutting symptoms measures level 2, and there you have this, okay? And you click there, and once that you click there, it's gonna download automatically, and you're gonna see something like what you are seeing right now in my screen, okay? And here, the first thing that you have is a cover page telling you like general information about the scale. The name is Promise Emotional Distress Depression short form. And as you can see, the rights are granted. So anyone, any clinician or researcher can use them for both clinical purposes or researching purposes, okay? And then when you go to page number 2, you're gonna see this. And what I want you to do is that I want you to answer this. It's very easy. Can you see? It's only 8 statements. And with this can give you a valid information if your client has depression or not. In this case, if you have depression or not. So you can print this or you can just do it in your computer, or you can do it in a piece of paper writing down the answers. So these are the instructions. On the DSM-5 level 1 cross-cutting questionnaire that you just completed, you indicated that during the past 2 weeks, have been bothered by no interest or pleasure in doing this and or feelings down, depressed or hopeless at a mild or greater level of severity. The questions below ask about these feelings in more detail, and especially how often you, the individual receiving care, have been bothered by a list of symptoms during the past 7 days. Please respond to each item by marking across 1 box per row, okay? So in the past 7 days, I felt wordless, never, rarely, sometimes, often, always, okay? So please go and do that. And when you finish, please let me know so we can go and you can score your own questionnaire.
Where is that located?
Go please, Michael, to the link that I shared with you in the chat. And once that you click that, you're gonna see a web page from the American Psychiatric Association that says online assessment measures. You have to go to the section that says level 2 cross-cutting symptoms measures.
Can you repost it? Because I had got kicked out, and when I came back in,
Yes,
you were explaining it, and when I go to chat now, there's nothing in chat.
Okay, here you have it again.
Okay,
Right.
Thank you.
No problem. Are you in the web page?
Yes, it's coming up.
Go to where it says level 2 cross-cutting symptoms, and you're gonna see that says for adults. The first option is level 2 depression adult. Click there.
Level 2 depression adults. Yes.
Click there.
Mm-hmm.
And you're gonna have the scale downloaded to your computer. Open it. And you have to go to page number 2 and answer the statements there.
Okay, I have it. Thank you.
No problem.
We can tally it up once we're done, right?
Did you finish now?
Yeah, so like I just counted it up and then I did it on the little.
Awesome.
Thank
The
you.
rest of you already finished? Perfect. Okay. So I'm gonna share my screen again with you. Once that you have the answers, now what you have to do is this. You can go here, scoring and interpretation, okay? Each item on the measure is rated on a 5-point scale, also known as a Likert scale, okay? With a range in scores from 8 to 40, with higher scores indicating greater severity of depression. The clinician is asked to review the scores on each item on the measure during the clinical interview and indicate the raw score for each item in the section provided for clinician use, okay? Here, you see? So here, what you have to do is, for example, if it's number 2, you just write down 2. If here is 4, you write down 4, and so on. The raw scores on the 8 items should be summed to obtain a total raw score. So once that you have all of them, you have to sum, and then you're gonna go to the total raw score, and you're gonna write down here the total, okay? Next, the T-score table should be used to identify the T-score associated with the individual's total raw score and the information entering the score row on the measure. So for example, suppose that you had 20, okay? And this is your raw score, 20, then the T-score will be 57.9, okay? Now, what you wanna do is that once that you have that, you want to go here where it says the T-scores are interpreted as follows. And in the case of a person with 57.9 will be mild, right? Mild depression. If it's someone who has less than 55 T-scores, is known to slight depression, and so on, okay? Now, what if a client doesn't answer 1, well, then what you have to do is that you need to prorate the total raw score. How are you going to do that? Okay, so here in the note, you can see it, okay? And it says, this lookup table works only if all items on the form are answered. If 75% or more of the questions have been answered, you are asked to prorate the raw score and then look up to the conversion to the t-score. The formula to prorate the partial raw score to the total raw score is the following. Raw sum by number of items on the short form by number of items that were actually answered. And that result, here you have an example, that result is going to give you, again, the raw score that you have to compare with the t-score, okay? So now what I want you to do is keep your t-score, keep whatever is the number that you have. Don't say it out loud right now if you want or not. And what we're gonna do is we're gonna have the class and we're gonna see all the symptoms of depression. I'm gonna try to explain you the best that I can. What is the depression? How do we treat depression and so on? And at the end of the presentation, I want you to think about the t-score that you had, the information that you had in this scale, along with the information that you're going to get from the presentation, and you yourself come with an opinion if you really have or you don't have depression. Because that's what we have to do with our clients. With our clients, we don't jump to a diagnosis only based on a scale. We use the scale to support our clinical judgment. So a scale like this can never, how should I say, a scale like this can never substitute your clinical judgment. And coming to a diagnosis only based on your clinical judgment can be very subjective. So that's why I encourage you guys to use both. Use an instrument such as this and your clinical judgment. And the good thing about this type of instruments is that they are very easy to answer. They are only 8 statements, 8 items. It's not like 75 or something like that. And this can be done in 3-5 minutes by the client. And once that you have this, and suppose that you have the diagnosis of depression for your client, you can use this instrument in every meeting if you want, or every month, or every other month. And with that information, with that data, you can compare if your client is doing better or doing worse, if you have been effective or non-effective in your treatment of your client, okay? All right, so how did you feel answering the questionnaire? What are your thoughts about the questionnaire? Did you like? You didn't like?
I liked it. I filled these out before, but never this short. I liked how short it was.
Mm-hmm.
And I think especially if you're going to be using that every session or almost every session with a client who does have depression, it makes it a lot easier to do, because it's like you don't have to be have that much energy or motivation to just answer 8 questions.
Correct.
You know?
Especially if you are depressed, right? People with depression, they are not motivated at all. Yeah.
I have another question. Is it more tools similar to this one?
Oh yeah, in that webpage, you have a bunch of them for adult, for children, for parents. That's why I have been sharing that since in the other class and in this class, because I want you to get familiarized with those scales. And as I mentioned, Michael, they are free to download and permission granted, which means that any clinician or researcher can use them without a specific authorization. And honestly, guys, this is awesome, because in the past, I was spending a lot of money buying and buying and buying scales for my clients. And with this, it's free, you download it, you can print them as many as you want, all right? All right, so I want to ask you, how was to read depression in the DSM-5? Can you tell me if you get any confusion or any ideas there that were not clear, or anything that you want to share about your experience reading about depression in the DSM-5? No brave student that wants to share with us? Okay.
I mean,
Yeah.
I usually have something to say, but I think it's just depression. I feel like it's just so comorbid with so many other things that I get really, this is again related to comorbidity. I'm sorry, I know I asked about this last time, but I do get like very confused as it doesn't really matter about like what the core diagnosis is. Like if, I guess is my question, because it's like depression can be connected to quite a few other things, and usually it's connected with anxiety at this point. They're usually diagnosed together.
Correct.
When you're talking about major depressive disorder, I'm like, I feel like that comes along with a lot of stuff.
Correct. And I think that the following slide is going to help us to answer that question. Okay, Alison? So I'm going to postpone the answer for a moment. Okay, so in this half section of the class, these are the two topics that we're going to see. We're going to talk about depression, and we're going to talk about bipolar disorders. In both, we're going to talk about the DSM-5 criteria, the diagnostic instruments, and the treatments for these type of disorders. But before we start with depression, I have these questions for you. How many of you have felt depressed in his or her life? Have you ever felt depressed, guys? Okay. Okay, pretty much all of you, right? What about you, Olivia? Would you say two? Okay, that's very interesting. Now, how many of you have had depression in your life as a disorder? Okay, 4 of you. All right, so all of you have felt depressed, but 4 of you have had the disorder. Now, the question is, what is the difference between feeling depressed and having depression?
What we talked about before, you can feel depressed, but you tend to still go along with your daily routines. Mm-hmm. You're getting up, you're going to work, what have you. But the depression disorder symptoms, laying in bed, staying in bed, not eating, it tends to, your actions, how will I say,
okay.
You tend to kind of things happen. I mean, you know, you don't go to work. You stay in bed. You know, you have a change in your lifestyle. Your lifestyle changes is what I'm
Okay.
somewhat saying.
That's okay. So now I have another question for you. What are the causes, the reasons for feeling depressed and for having depression? What is causing depression or feeling depressed?
I guess something that can cause you to feel depressed is like the everyday factors of life. So like, you know, like Mike was saying, things happen. It's even a very popular slogan that says sugar honey iced tea happens. If you don't know what sugar honey iced tea is, take the first letter of each word and you got the word it is. But stuff happens, and when things happen, we can take those emotions and those feelings and we kind of like compartmentalize it, and it becomes like a part of who we are. So like we like something can happen. For example, I wasn't feeling the best, so I automatically got sad because now things that I have planned I can't do. And like I even so much as to got upset about it, and I was like, oh well, I'm just gonna stay in bed because now everything is messed up and I can't do anything. And that was just like a depressive moment versus someone who is depressed. It's like I don't want to necessarily say a lifestyle, but it kind of like takes over their entire life. So like that feeling of, I don't want to do anything, I'm upset, I'm sad, I want to stay in the bed every day. It's something that happens day after day after day. Like the joys of life are no longer there type
So
of feel.
seems that what you are saying, Jasmine, is that the feeling of depression, the feeling of depression is a reaction to something going on in our life. And I agree with that. If we go to Twitter and we scroll down today, it can be a very depressive experience, right? Because all the confrontation going on related with the elections. But now, what about the depression as a disorder? What is the causes of depression, of the disorder? Is
Like
it
grief
also a
of death.
reaction?
It's like from grief of death or loss of a job or, financial instability. It could be of any of those factors that will cause you to feel depressed
Okay.
with no hope.
What about chemical imbalance?
Okay.
And the reason I mentioned some type of maybe chemical imbalance because my daughter diagnosed with depression. Now, she maintains her job. She has, no children for extra stress. I mean, she literally has no extra stressors, but to us, she has no extra stressors. But to her, for some typical reason, the chemical imbalance, she just feels depressed. Now, I don't know if, and she also has, like Ali said, she has anxiety. So it tends, like she said, depression, anxiety tends to just follow along with each other.
Okay, so Crystal is telling us experiences in life. Michael is telling us chemical imbalances. And Alison wants to say something.
Yes, I do.
And then
And
I thought it was interesting, like, and I mean, when you said that, I obviously looked at development and course again, but it wasn't in there. I think it's in like the temperament. I think neuroticism as a child. And so I thought that, I remember reading that and thinking that was really interesting because I was quite neurotic. I still am, I think, in a lot of ways, but I was a very neurotic child. So I think a lot of it, and maybe this is what you're getting at, has to do with process of thinking, the way we think, the way we feel. How we're taught to think, even if it's by watching other people. I do think that plays a big role for a lot of people in being diagnosed with depression, and then changing thinking is connected a lot to depression.
So that neuroticism that Alison is telling us is part of what is called the Big Five model in personality, okay? And these are personality traits, and that's correct. People with neuroticism, they have less self-control, and therefore they have a higher tendency to experiment mood disorder and anxiety disorders. Okay, lastly, Ashley, please.
I think that a lot of like depression and like being diagnosed with it and stuff has to do with a lot of trauma. And kind of along with like what Allie was saying too, but definitely the trauma, because I know that that's how, I have dealt with it. And then once you have that depression, like Allie said again, like you have that anxiety too. So then you're worrying about your worrying, which makes you even more depressed. You don't want to get up. You don't want to do normal things that you would normally do every single day.
That will go a little bit in the same line that what Crystal was saying, right? Experiences in life that they are stressful for us, and then we develop this response to those experiences. Now, the question is there any good on having depression? What could be positive of having a depression, Alison?
And I don't know if this is where you were going or getting at with this, but I definitely feel like it connects to grief and suffering. So it's like when something bad does happen, it's not very surprising. And it's also not something that you're like, oh, I can't handle this. It's more of, okay, this is how a more extreme version of how I feel fairly regularly. So I can, I don't know if that makes any sense, but the grief is not as overwhelming because you're constantly grieving.
Okay, so I have the following slide for you guys, and that I want to share you from a great writer. This is a quote from this great writer. His name was Rainer Maria Rilke. If I remember well, he was from Austria, but I may be wrong. And he says, why would you want to exclude from your life any uneasiness, any pain, any depression, since you don't know what work they are accomplishing within you? So one of the things that has been problematic in psychopathology, guys, and this is true for psychology, counseling, psychiatry, and so on, is to think about mental disorders as a negative things that we need to get rid of them. And I think that some of the psychological models that we are using, or psychotherapeutical models that we are using, they can reinforce that idea. For example, CBT, or for example, psychoanalysis, they could reinforce the idea that having these mental disorders is something negative and that you need to get rid of them. Also behavioral therapy, although they don't talk too much about disorders, mental health disorders, they just talk about adaptive or maladaptive behaviors. Perhaps some other models like existentialist therapies, they don't talk as much as mental disorders being something negative. But what we need to have in mind is that these are human reactions, and we're experimenting these negative emotions, these negative reactions for a variety of reasons. In reality, we don't have a clear understanding of why people get depressed. We know that there are biological elements such as genetics, chemical imbalance, as Michael was saying, problems with the structure of our brains, and even inflammatory process. You will see there's a correlation between the bacteria in our guts and depression. As you may know, we have more bacteria than cells in our body. And many of those bacteria are very positive for us. They help us to stay healthy, both physically and mentally. And has been proven that people with depression, they have an imbalance of the bacteria in their gut, and they have more bad bacteria than positive or good bacteria in their body. So there are many things that could be behind of depression. But what we know is that depression per se is not bad. People have this tendency to think that these mental problems or that suffering or that pain is something that it's bad and we need to get rid of it. But as Rilke is telling us, we don't know what work they are accomplishing within us. Many people that have struggled with these type of things, they have come out in better versions of themselves. Or as Alison was telling us in our last class about Vincent van Gogh, right? All that suffering that he was experimenting, it was also connected with all the beauty that he was creating. Now, we cannot say that now let's all of us to provoke suffering in order of creating something beautiful. But what we are saying, it's not an apologetics of suffering, but what we are saying is that it is not necessarily something bad. Maybe it's painful, maybe it's something that we don't want, but maybe it's also an opportunity. And specifically talking about depression, I see depression as an opportunity to think about ourselves, to think about what we are thinking, to stop for a moment, seeing what is outside and to start seeing what is within us. Now, the problem is that our clients, they think so much about those things that they forget that there's also an external reality that they need to share and that they need to interact with it. So keeping balance is a huge challenge for them. All right, so by the way, I suggest you to buy the books of this guy. He was a very good writer. Now, there's something important to have in mind when we are talking about depression. There's a lot of what's the word that I'm looking? Stigma around depression. And people think that depression or the stigma around depression is that it's for people that they are weak, for people that they don't have willpower, or people that they are just lazy. And because of that, everything is under power to get rid of the depression. But in reality, it's not like that. You will see depression is one of the most common mental health problems that you will see in your meetings with your clients, and you will notice that many of those clients are really strong people, that they really have a willpower, and that they are able to accomplish many things, but their depression is causing damage. They are struggling with their depression, and because of that, they are not having the outcomes that they will be able to have if they were not having depression. But I think that what I'm trying to highlight here, guys, is that depression is not a sign of weakness. Think about these three guys that I'm sharing with you here: Winston Churchill, Leo Tolstoy, and Abraham Lincoln. So Winston Churchill is the savior of the Western civilization in World War II, right? We cannot say that he was a weak person or that he didn't have willpower. But his biographers have been saying that he was experimenting depression since he was little. And not only that, some of them says that also OCD and alcoholism. There's a story about him that a lady come to him and said he was drunk because he was drinking a lot. That's for sure. And this lady come to him and says, like, you should be embarrassed about yourself. You are drunk again. Shame on you. And he turned around and he answered the lady in the peculiar way that he used to answer. And he says, look, lady, my alcoholism problem has a solution. Tomorrow morning, I'm going to wake up hangover and I'm not going to be drunk anymore. But your ugliness, it doesn't have a solution, because tomorrow morning you're going to wake up and you're going to still be as ugly as you are today. So don't stay with your own business and don't bother with my business. That was Churchill, right? And he was the person who called his depression a black dog. That's how he called his depression, a black dog. And he was saying that since he was little, he was experimenting this black dog in his soul. But also Leo Tolstoy. Leo Tolstoy, if you don't know him, he's one of the most important writers of all the times. He is Russian. He wrote War and Peace, a beautiful book. He also wrote other books such as The Death of a Horse, also The Death of Ivan Illich, and a beautiful book that I strongly suggest you to look for it, that it's called Calendar of Wisdom. And this guy, who was one of the most important writers of all the times, he was so depressed that in his diary, he's saying that he's so afraid of himself that he has to keep all the knives and all the shape objects of his house outside of his house, because he's afraid of killing himself with the knives. And guess whom else? Abraham Lincoln. Yes, the same Abraham Lincoln, he was experimenting depression. So we cannot say that those prejudice or stigmas around depression are true. And you are also a testimony, a witness, and evidence of that, because all of you have said that you have felt depressed, and 4 of you said that you have had depression as a syndrome. And look at you. You are here. You are working to accomplish the goal of becoming counselors. And I am very sure that your own experience with depression is going to be very useful when you are working with your clients. It's going to increase your empathy, and it's going to increase also your clinical judgment. All right, so that was the introduction. Now, what is the DSM-5 telling us about depression? Yes, go ahead, Michael.
No.
Ah, okay.
I coughed.
Okay. So the DSM-5 is telling us that the criteria A is the following: 5 or more of the following symptoms, and they have been present during the same 2-week period and represent a change from previous functioning. And at least one of these symptoms is either symptom number 1, which is depressed mood, or symptom number 2, which is loss of interest or pleasure. So pay attention to these guys. 2-week period, okay, at least. So we all can feel depressed, but generally speaking, a feeling of being depressed is something that is gonna go away the same day or after 1 day or 2 days or 3 days. Maybe things are start looking better for us. Maybe we start receiving good news, or maybe we start doing something with our life and that feeling of depressed goes away. Now, the disorder is something that doesn't go away that easily. So the person needs to feel depressed at least for 2 weeks in order of calling that depression, okay? And also a loss of interest or pleasure. So many people who they feel depressed, if you say like, hey, let's go to the outlet, they have very good savings, they're gonna be like, oh yes, let's go. And that's gonna help me to feel better. I'm gonna spend some dollars and I'm gonna buy a nice shirt and I'm gonna feel better. Well, that's not depression. That's just a feeling of depressed. Or people that they are having that feeling, they might go with their friends and spend a good time with their friends. And after that, they don't feel depressed anymore. That's not the case with people with a disorder. This is a syndrome, a disorder, and they lose interest in all those things or activities that are pleasurable for them. So the symptom number 1, depressed mood most of the day, nearly every day, as indicated by either subjective report, what they are saying, a feeling of sadness, emptiness, or hopelessness, or observation made by others. You see, or the relatives see the person tearful, sad, and so on. Now, have in mind, guys, that in children and adolescents, instead of sadness, it might be irritable mood, okay? So, but again, look what the criteria was telling us. It represents a change from previous functioning. So you can have a children that maybe he's angry, right? Irritable, but when you ask about it, they say, well, he has been like that since the beginning, right? All the time, he's like that. He's a difficult child. Okay, so that's important to have in mind, because when we are diagnosing this, is something that you can see as a different way of feeling and behaving as the common way in the client, okay?
Why is it only in children that you would use irritability instead of sadness?
That's a good question. You can see irritability as well in adults, but not as the main symptom. In adults, you will see sadness or emptiness or hopelessness as the main symptom. And perhaps the reason has to be that with children, they are still not able to understand their emotions very well and to express their emotions very well. And because of that, they have what we call acting out of the emotions, right? So this acting out of the emotions is what I cannot say or understand or to express. I'm gonna act, I'm gonna behave. That's very common in children. However, it is also very common in personality disorders. We will see that, for example, in borderline personality disorder, which they are pretty much like little kids that they don't have self-control, right? And because they don't have self-control and they don't understand their emotions, they have a lot of acting outs. All right, make sense?
Yes.
Awesome. So the symptom number 2, markedly diminished interest or pleasure in all or almost all activities, most of the day, nearly every day. Now, this is something that we call anhedonia, okay? Anhedonia. And we're gonna see this not only in depression, later on we're gonna talk about the schizophrenia, We're going to talk about negative symptoms in schizophrenia, and they have these symptoms too. But here, it's important to have in mind that this anhedonia, it's a very clear, evident change in the mood of the client. So before he or she he used to enjoy joining his friends. Now he doesn't enjoy that anymore. She used to enjoy hanging around with her friends. Now she doesn't enjoy that anymore. He used to enjoy reading. Now he doesn't enjoy reading anymore. So that pleasure goes away. Symptom number 3, significant weight loss when not dieting or weight gain, okay? Or decrease or increase of appetite nearly every day. So this is very interesting. We have a tendency to think that those who are gaining weight or that they are eating a lot is because they are depressed, but sometimes it's the opposite too, okay? Same thing with the sleeping pattern, insomnia or hypersomnia. Number 5, psychomotor agitation or retardation nearly every day. So you can see that the DSM-5 is giving us like opposite symptoms, right? Psychomotor, yes?
I have a question about those criteria. Like, is it possible for someone who is experiencing depression to like experience symptoms on both sides of the spectrum? Like, for example, like at some points they have a high appetite and they gain weight, and then like, you know, later on their like appetite has completely changed, and like, or if they're sleeping super sleepy at one point and then the next time they're not, like.
Absolutely. Is
Like
it possible?
simultaneously, can they experience those?
Absolutely. Now, how do you want to know that those changes, those swings, right? It's symptoms of depression. Well, if you see either symptom number 1 or symptom number 2, okay? That's why the criteria A is telling us at least one of these 2 symptoms needs to be present. If you don't see any of these 2 symptoms present and you see your client moving from one extreme to the other, either in sleeping pattern or eating or in psychomotor activities and so on, it might be something different. Perhaps it's an anxiety disorder, or perhaps it's something else, but not depression. It is depression only if symptom number 1 or symptom number 2 is present, okay? And fatigue or loss of energy nearly every day. So let's go to the final symptoms. Feeling of worthlessness or excessive or inappropriate guilt, which may be delusional nearly every day, not merely self-reproach or guilt about being sick, okay? So this is important because they think I'm worthless, I'm good for nothing, or it's my fault that the problems going on in my family, and therefore I'm guilty for that, okay? It's like very severe judgment about themselves. Number 8, diminished ability to think or concentrate or indecisiveness nearly every day, okay? So the attention is very poor. And number 9, recurrent thoughts of death, not just fear of dying, guys, but thinking on death as a solution, recurrent suicidal ideation without a specific plan. Maybe they are planning, saying, I would like to die, I would like to kill myself, but they don't have a plan on how to do it. Or maybe they do have a plan and they are willing to attempt or commit suicide. So these are like 3 different levels, you see? One is the person who thinks, I wish I would be dead. In that way, I wouldn't be suffering on this. And then you ask, have you considered to kill yourself? And they say, no, I would like to be dead, but I'm not brave enough to kill myself. They say something like that, right? The number 2 is those that say, I would like to be dead, and I have been thinking in killing myself. And then you have to ask, do you have a plan to do that? Have you think on how would you like to kill yourself? If they say no, okay, That's like the second level of severity, right? Now, the third level of severity is when they say to you, I want to kill myself and I know how am I going to do it, right? So these are three different layers of severity of this symptom number 9. And the way that you're going to react to these three different levels of severity is different. In the first one, you're going to say something like, I understand that you are feeling like that. Sometimes when life seems overwhelming, we like to think in death as a solution. However, I celebrate that you are only thinking in that way and that you are not thinking in a more risky way or in a more dangerous way, because the good thing is that you can overcome the problems that you are having and also overcome these feelings or this thinking about death as a solution, and perhaps find joy again in your life. And I'm going to be more than happy to help you with that. Okay, that's for number 1. Now, for number 2, you need to react in a different way and say something like, I understand that you feel like that. Life seems complicated right now for you, overwhelming. And when we are in that place, well, it's common to think about death and even to think about killing ourselves. However, you know that I really care about you, that I care about your integrity. And this is very concerning for me because I don't want to see you dying, or I don't want to see you dead or killing yourself. So I was wondering if we can make a plan. First, if we can assess a little bit these thoughts that you are having. Are you thinking in killing yourself, but from 0 to 100, how likely is that you're going to try to do it? If they say to you 100, well, that's very dangerous, right? If they say 50%, well, that's not as dangerous. So after that, you want to have a plan with them, and you're going to say something like, well, I understand that you think in that way and that you feel in that way, but I also know that with the treatment that we're going to have, you're going to start feeling better sooner or later. And perhaps those feelings and those thoughts of killing yourself are going to go away. So I want to ask you a compromise, that you and I can have a compromise together. And that compromise is that before anything happens, before you trying or even thinking on killing yourself, you're going to let me know. And your part of this compromise is that you're going to let me know. And the part of my compromise is that I'm going to be there for you. Either I'm going to answer back the text message, or I'm going to call you back, or we're going to have an extra meeting so you and I can discuss what's going on with you. Can you promise me that? And if the client says, yes, I can promise you that, that's a very good sign. If you don't trust in your client, you can say like, would you be okay if we include someone else in this commitment? Perhaps your wife, or perhaps your parents, or your friend, so they can know about this. And maybe you can also contact them if you are feeling in that way, not only me. What do you think about that? This is always good, guys, because you are providing another option for them in case that you are not available in the moment. But also it can protect you a little bit in case that they really try to do something. There's a witness, and that witness knows that you have been addressing the situation. You have not been imprudent, okay? Now, in the third level, like in the person who says like, yes, I have a plan and I want to kill myself and I think I'm gonna try. Well, that's a completely different level of severity, right? And you don't want to take any risk. And the first thing that you have to say is like, you know what? I understand that you are thinking in that way, but I am really concerned about you. So I would really like to focus this session to see why are you feeling in that way? Why are you thinking in that way? And see if you and I can do something to decrease the chances of that happening. And you're gonna work the whole session with him or with she, asking why, what's going on, identifying the thoughts, trying to work with the cognitive biases behind them, and trying to do some reframing of thought and so on. If at the end of that, the client's still thinking on killing himself or herself, then you need to do the next step, the next move, and that is telling him that you cannot allow him, not like that, but maybe you're gonna say in a positive way, you know, we have been working a lot trying to just encourage you to do that, and I see that you are still thinking on that, and I don't want to take that risk with you. I don't want to take a risk of losing you because you are important for me, because your suffering is important, and because I also know that there's hope after all this darkness that you are having. And because of that, I'm going to need to call someone in your family or to call 911 and ask them to admit you in the hospital so you can relax yourself a little bit. They can start some medicines with you to help you to feel better, to relax a little bit. And then you and I continue working in our therapy. What do you think about that? Some clients are going to say to you, I don't want that. And I don't want you to call them. And at the end is your judgment, okay? At the end, it's up to you, because if that client goes away from your office and you didn't make the call and he kills himself, you might be in troubles, okay? You might be in troubles because you didn't make that following step. Am I clear with all these, guys?
Yes.
Okay. All right. So it's important to have that in mind, guys, okay?
Can you hold the patient if the
Sorry?
patient tells you that they want to commit suicide? Can you hold them and call maybe ahead if they agree to go to the hospital?
Yeah, like you mean like involuntarily, Michael?
Voluntarily. If they voluntarily say, if they tell you that I'm depressed, I feel like killing yourself, your suggestion, like you mentioned, is for them to admit themselves, and you ask them, will you go voluntarily? Can you call ahead to have them voluntarily?
Absolutely. And actually something that I will suggest you to do. Hey, this is an important step and I want to be with you as much as I can. Can we call the ambulance here together?
Okay.
And it's also giving you some guarantees, right? That he's really going to the hospital, because if he says to you, okay, that's okay, as soon as I arrive home, I'm gonna call the ambulance.
Exactly.
He never arrives home, right? And he kills himself in his way home. So
right.
You want him, you don't want him to leave your office by himself if he is still wanting to kill himself, Michael. So you either call the ambulance or you either call a relative and you ask the relative to come and to help the situation, okay? That way you don't have the responsibility on your side. And once that you call the ambulance, it can be even a good idea to go with him to the hospital, okay? Maybe you can go in the ambulance with him, and once that he's admitted, you will not be allowed to see them, because that's the way that hospital works. They have their own counselors and so on. But you can tell him, you still can send me messages, and I'm going to be waiting for you once that you are discharged of the hospital. So you and I can resume our meetings, okay? Promoting that as a temporary measure. All right. Okay, so that's criteria A with all the symptoms of depression. Now, criteria B is the symptoms cause clinical significant distress or impairment in social, occupational, or the important areas of functioning. And C, the episode is not attributable to physiological effects of a substance or another medical condition, okay? Some clients with cancer, for example, or diabetes, they can have very severe symptoms of depression, but they are likely to be part of that syndrome, not a specific disorder, okay? They can be symptoms of their cancer or their diabetes, and not a disorder per se.
I had a question about this while I was reading it, because I feel like that there's multiple physiological, like a physical disorder or a physical problem that has symptoms that are would fit 5 of these things underneath depression. So it gets,
Yes.
to me, that gets really complicated because it's like, what are you going to do? You can't run blood tests on them or force them to go to the doctor. And not only that, but like, who knows if they'll even figure it out in a regular physical examination? Because like, the reason I'm saying this is very similar to my life right now. So like, finding out that there's a physical problem that could be causing a lot of the depressive symptoms, I feel like is pretty important. But it's like, what can you do as the counselor to, I don't know, help them figure that out, I guess?
A lot. First is that's why when we are doing the intake and we are doing the assessment period, we have to ask about their physical health, right? How are they sleeping? How are they eating? If they are working out or not, if they have pain or not, if they have a lack of energy or not. And you're receiving all that information and you're building your hypothesis on what's going on with the client. And if you have some red flags there, you need to ask them, hey, I see some red flags here that they might be part of some physiological problem. And I just want to corroborate that, to be clear about that. So I will ask you, please go with a physician so you can have an assessment by a physician and that we can be sure that there's nothing going on in that arena. Now, if something comes out, that doesn't mean that you are not going to work with the client anymore. Now, what you're going to say to them is, this is a very good news because now we know that something, I mean, it's not good that you have a disease, but it's good that now we know that you have this disease because now we need to work with that disease from a medical perspective, but also we're going to work from an emotional, psychological perspective and see how are you doing with that. If you are following the doctor's recommendations, if you are doing what is on your side to get better or not. Because as we have talked before, Allison, there's no division between body and mind. Body and mind, they are a unity, they are interconnected. What affects the body affects the mind, and what affects the mind affects the body too, right? So you're gonna work with that client to increase adherence to the treatment, to analyze the type of thoughts that they have about their illness, because perhaps knowing that they have that illness activates some irrational automatic thoughts and even some schemas, right? That they can interfere in the treatment of that. Now, some of these diseases, they can be really severe and impacting their life in many ways, such as cancer, right? Or diabetes. They are really affecting life. Therefore, they're gonna have an emotional consequence of those diseases that they need to be addressed by us, the counselors. Doctors, they don't address those things. And the client needs to talk about that and needs to work with that. And research is showing that people with this type of illness, if they have counseling, 2 things very important happen. 1, they increase adherence to the treatment of their illness. And 2, they recover faster and with less relapse than those who doesn't have counseling. So we are still important when we identify that there's a physiological problem. Having said that, if the main diagnosis is going to be a major depressive disorder, you require ANC, which means that the depression is not the result of the cancer or the result of the diabetes.
How do you determine that?
Because
is that even determinable? Like, I don't feel like it is.
You want to see what was first. The client
How do you know? Chicken or the egg?
Sorry?
True.
I said, how do you know, chicken or the egg?
Yes, I know. It's not easy, but you want to ask those questions, right? Since when have you been feeling in that way? Do you think that you were feeling in this way before you were ill, or was when you start being ill or after being ill? And you start going to those in that direction in your questioning so you can get that information. Now, suppose that you don't know. Suppose that you cannot come with a conclusion. Does that mean that you are not gonna say that your client is depressed? Of course not. You're gonna explain to him, you have a depression. Now, what we don't know is if your depression is the result of your cancer, or if your depression it was before your cancer.
So would you consider if it was after the cancer, then it would be like life circumstantial depression rather than major depressive disorder? Or like, how would you even write that as in concern with insurance and things like that?
You can still write down major depressive disorder, but because the way that you're going to treat the client is going to be the same, right? Now, the important thing here for us, Alison, is that if you identify that the depression is not a disorder by itself, but it's a symptom of a physical illness, that's really important information, because then you know that that client needs to be treated. And for example, with diabetic clients, once that they start receiving diabetic treatment, most of them are not going to experiment depression anymore. And this is telling us a lot about how depression works. Remember that I was telling you it's a combination of physical, biological factors, and environmental factors, and psychological factors. And sometimes it's just the result of biological problems going on that the client is not addressing appropriately. So, but yeah, okay. So I think that the way this works is to try to protect your client in not misleading your client to think that he has a solo psychological problem when he might have a physiological problem too.
Sorry, it's very curious to me because it becomes cyclical really quickly, where it's like, you know, what caused what, where did it start, how do we know? And also, like, once somebody, you know, goes through that, I mean, your brain changes, like you've created new habituation. So it's like, then you have to, you kind of, and some people probably would end up with depression after having a major diagnosis like cancer, like, you know, like, because then you're habituated to.
Yeah, but just think about this, Alison. If you are saying that you have cancer and after that you start receiving chemo and then radiotherapy too, and then you start seeing yourself losing your hair, losing all your strengths, losing all your activities, and then you are spending most part of the time in bed on pain and not being able to do the things that you enjoy and so on. Well, the depression in that case is not only normal, I will say it's even adaptive. The depression is a response to a very miserable situation that you are experimenting, and there's nothing wrong with your depression. So the way that you're gonna work that depression is different with your client, because you're gonna explain to the client, this is a very understandable reaction to the situation that you are having. But now if you have a client that he doesn't have any medical illness, that he has apparently a very good job, a very good life, a nice family, a nice house, a nice social life, and so on, and he's depressed, oh, we need to try to understand why. If everything seems to be perfect, and the why is gonna lead you to the how I'm gonna treat this, right? Maybe the why has to be with his childhood, with his schemas, traumatic events that have been solved and they have been activated again. And then the how are you gonna treat that is completely different, because now you have to work with things of the past and to try to reestablish those situations in a different way and so on. So I think that that's why it's important. But again, it's not as clear cut to say that mind and body are two different things, guys. Okay, time is running, guys, and I just want to finish depression so we can go to the break, okay? The prevalence, as I was telling you, this is one of the most prevalent disorders that you're gonna experiment and that you're gonna see in your clients. So it's important for you to have that in mind. Depression and anxiety is the most prevalent type of problems that we are seeing in our meetings. And this is what Alison was telling us at the beginning, the risk and prognostic factors that the DSM-5 is giving us. So temperamental level, neuroticism, that means a tendency for a lack of self-control and experimenting high levels of emotions. Environmental factors, adverse childhood experiences, stressful life events. Genetic and physiological. Well, it's very interesting because we really have evidence that there's some genetic components. How do we have that evidence? Well, if you have a first-degree family member with depression, you increase the chances by 2 to 4 times to have depression. And now in the twin studies, we have seen that there's a 40% heritability. But take a look on that, guys. It's only 40%. When we talk about schizophrenia, I'm going to explain you more about the interrelation between genetic elements and experiences, because genetics cannot explain everything, okay? And physiological problems cannot explain everything. We know that many people who've cancer, they don't get depressed, for example. Or many people with diabetes, they don't get depressed. Or people who they have parents and grandparents that they were depressed, they don't get depressed. So it's only the 40%. Course modifiers. Well, other mental disorders such as substance abuse, anxiety, and borderline personality disorder, and chronic and disabling medical conditions, they all put in risk the person to develop depression and also to have a less positive prognostic, okay? And so the instruments to diagnose depression, we already talked about the severity measure for depression. Then there's the Born's depression checklist. You can check that. It's also very easy to use. And we're gonna finish. Okay, let's go to do the break, guys. We're gonna take 10 minutes and then we're gonna watch this video and I'm gonna talk to you about a client that I had, okay? So it's 7:18. I will see you at 7:28. Okay, now I'm recording and I don't know if you were able to listen or not. Yes? Okay. So sorry for that, but I forgot about Janet, so I'm gonna start since the beginning.
Depression creeps up on you quietly. At the very beginning, you struggle with the little things, but you usually just ignore them. It's like a headache. You'll tell yourself it's temporary and it'll pass. It's just another bad day. But it's not. You're stuck in this state of mind. You get used to putting on a social mask and you continue to live among other people because that's what you have to do. That's what others do. However, the problem does not go away. You struggle to put on a play every day and it starts to cost you more and more. That is why you fall even deeper, and that's when you slowly start to back away from friends and family, sometimes completely shutting them out. All satisfaction is gone. The little things that used to bring you joy are now worthless. Even the simplest tasks become painful. And that is why you lack motivation now. Why would you keep on trying if nothing makes you happy anyway? All of this makes you feel even worse and you get caught up in a vicious circle. Suddenly you find yourself living in slow motion. Days become indistinguishable, just white noise, just heaviness filling your mind and spilling over your body. You feel as though you will never be happy again. You continue to back away and destroy relationships. You're ashamed for everything you've done and everything you haven't. There is a part of you that wants to make things right. A sudden positive upsurge makes you want to go out and meet people, but it's all very short-lived because you know it won't work anyway. Things that make your friends excited leave you indifferent, and you become aware of the huge gap that lies between you and other. Failure is not an option, so in the end you choose to be alone in your comfort zone where no one asks any questions. Low self-esteem and the lack of purpose become unbearable. You finally realize you can't go on that way, and two things can happen. You either decide to get some help, or you might attempt a suicide.
All right. So something that I like from this video is that I think that it's quite realistic. I don't know, what do you think, those of you that have experienced depression? Did you feel identify?
Yeah.
Okay. And the end of the video, I think it's a really important message for all of us. Clients with depression, they don't tend to get better by themselves and with the time. Clients with depression, either they look for help or their depression is gonna increase, it's gonna be more severe, and they can commit suicide. So that's why we want to be serious about depression, okay? All right, so let me tell you about this client. She's a female, 2 years old. Some of her antecedents, she was adopted. Her biological mother, she was adopted by the boyfriend of her biological mother. Once that he finished the relationship with the mother, he adopted her because the mother, she has borderline personality disorder, very complex situation with the mom. So the stepfather is an old mother's boyfriend. The biological father, he was absent until she was 21, and she looked for him, not him for her, but she for him. And the biological father seems to be high neuroticism and episodes of depression. She has a histrionic personality, but he doesn't have histrionic personality disorder. She also had an abortion, and after that, she started having like a lot of symptoms of depression, and then she started having a lot of, I would say, erratic romantic relationships. So she was having a lot of how do you say it, guys? One night stands. Yeah,
one night stands.
Yeah, with many guys. So it seems that it was like a way of coping with all the that she was dealing with. So some of the symptoms: insomnia, emotional ability, depressed mood, lack of interest, feeling of worthless, lack of concentration, alternate with high functional periods. And her cognitions: my life is worse than the majority. I will become as my mother. I cannot control my emotions. There's nothing I can do to be better. What would you do with a client like that? Where would you start? It's a very challenging case, right? We can see that there's some biological elements there. The mom with a very severe disorder, the father, the biological father with a very highly, I would say, like with also some things going on there. Then she had a stepfather. He was a good father, the stepfather. He was very good with her. But then she was very erratic in her relationships, and then she started making decisions that she regrets, such as the abortion and so on, right? So when you have a client like this, it's very difficult to say that it's a biological problem or it's a life experience problem. It's likely that it's both of it. And what you want to work with this client is that you want to have baby steps, okay? So you want to start working with the client in order of bringing order to the life, that she can have a more stable life, that she can identify what are the things that are increasing or decreasing the depression. And at the same time, you want to work with two possibilities. Possibility number one, counseling alone, and possibility number two, counseling plus medicine. So there was a moment that we started working with the medicines too, but something very interesting happened. She realized that every time that she was taking the contraceptive medicines, she was also having a depressive episode. So she struggled a lot because it was not only that things of the past, but things of the present, and apparently the way that her body was reacting also to those contraceptive medicines that she was taking and so on. So it was a very challenging case. At the end, we worked for a long time, and at the end she was depression free, but you can still see some of the personality traits going on there. And this idea of I will become as my mother, it was a really threatening idea for her. And I guess that she might have some personality disorders as well. Maybe not as severe as the mother, but she was having more than depression, that's for sure. All right. So how do we treat people with depression? So you have the selective serotonin reuptake inhibitors, or SSRIs, which are the appropriate medicines to use in depression because they have fewer side effects in comparison with other type of antidepressants, although they are not free of side effects, guys. Some of those side effects are loss of libido, gain weight, and things like that. At the same time, you don't want to start with the medicine unless that they are in real danger or that there's a history of psychotherapy not working for them. But if you don't have that history or the severe of the depression is mild or moderate, you want to start with psychotherapy, with counseling, okay? So based on this research, you can click there and you can see it. CBT is an effective treatment for adult depression. No evidence that CBT is more effective than other psychotherapies. It remains the best studied type of therapy though. So this is interesting. What it's saying is that other type of therapies can be as effective as CBT. The thing is that we don't have as much research done in other type of therapies. But when we do have that research, they are pretty much similar in the effect that they are having. Now, why is that we don't have too much research in psychoanalysis or humanistic and so on? It's because they don't care. Because their theoretical understanding of human behavior, it's more oriented to subjective experience than to objective experience. And because of that, they don't care about doing research. So that's why we have so much research in CBT and in behavioral therapy, but this is telling us that it's not necessarily that it's better than the others. Combined treatment of CBT and pharmacotherapy is significantly more effective than pharmacotherapy alone. This is especially true for severe cases, okay? All right, so more of the same. I'm gonna skip this. And I want to encourage you to go and look for this article in Psychology Today. It's a very comprehensive reading, very clear. You will not have problems understanding the information. What is the best way to treat depression? Psychology Today, okay? So go there. You're gonna have a lot of information, very clear, and it's gonna help you to have a better understanding on that. All right? Okay. Questions, comments so far about depression? All right, so let's go with bipolar disorder then. And I have a question for you guys. I'm gonna see if you did your readings or not. What's the difference between bipolar 1 and bipolar 2? The main difference.
Is it the manic and hypermanic?
Okay, Crystal. And which one is the one who has manic episodes and which one has hypomanic episodes?
Bipolar 1 has manic, and bipolar 2 has hypermanic.
Okay, so thank you, Crystal. And with that, you can see also the severity. Bipolar 1 is a very serious disorder, okay? Bipolar 2 is important disorder, but it's not as severe. And then there's a third type of disorder that it's called cyclothymia, okay? Cyclothymia is like a light version of bipolar disorder. And I'm gonna tell a little bit more at the end of the presentation about cyclothymia, that it seems more like a personality characteristic, a temperament characteristic than a disorder per se. So these are the topics that we're gonna see: manic episodes versus hypomanic episodes, the criteria for bipolar 1 and 2, prevalence, risk, and prognostic factors, diagnostic instruments, and the patient perspective and treatment options, okay? So what is the difference between a manic episode and a hypomanic episode? Well, it's intensity, okay? The severity of the episode. The manic episode is a distinct period of abnormally and persistently elevated, expansive, or irritable mood and abnormally and persistently increased goal-directed activity or energy, lasting at least 1 week and present most of the day, nearly every day, or any duration if hospitalization is necessary. So it's no euphoria, guys. It's more than that. It's been out of control, okay? They feel an intense level of euphoria. They feel that they are invulnerable. They feel that they need to be very active. You will see some of these clients, they don't sleep for days and days and days in a row. They don't sleep. They have a lot of energy. They have a lot of risk sexual behaviors with people that they don't know, a lot of risk behaviors regarding violence, such as driving super fast in the highway while they are under the effect of substances, or getting in physical fights with other people, or just going and making very expensive buyings, right? Using the credit card and using a lot of money for those purposes. So they are really out of control. Now, what's a hypomanic episode? It's a distinctive period of abnormally and persistently elevated, expansive, or irritable mood, and abnormally and persistently increased activity or energy. So you're gonna be like, it's the same, lasting at least 4 consecutive days and present most of the day, nearly every day. So first difference is that the duration, right? They don't last as much as the manic episode. And second difference, these hypomanic episodes are not as severe as the manic episodes. They still feel a lot of energy. They are still doing poor decisions, but they have more control of themselves. Now, this is going to help us to have a better understanding of the difference, okay? So you have mania and hypomania here and the criteria. So minimum time frame for diagnosis, mania is 1 week, hypomania is 4 days. Number of symptoms for diagnosis, both at least 3 of these, okay? What are those symptoms? Grandiosity, I am awesome. Decreased need for sleep, more talkative, flight of ideas, distractibility, increased goal-directed activity, risky behavior. All of this, yes, for both of them. Marked impairment of social occupational functioning. When they are in mania, they have a real impairment, either in their job, in their school, or with their family. But in hypomania, they don't, okay? They may still be able to go to work, may be able to still go into school. And people are gonna say like, what's going on with you, man? Have you been using substances? Are you high or what's going on? You seem different. And they might be like, no, nothing, I'm awesome, I'm feeling very good. What's the problem with that, right? But they are still able to do the job. Psychotic features. In mania, yes, they may have delusional thinking, they may have hallucinations, they may have disorganized speech, and so on. In hypomania, they don't have. May require hospitalization, mania, yes. And I will say, yes, please, because they are in danger of themselves, putting themselves in danger, and they are putting others in danger. In hypomania, no. Generally speaking, with the medicine, they start doing better. And if you put them to sleep, they start doing better, okay? But in the mania, it's very difficult that they're gonna get better if they are not hospitalized or if they are not in a very good dose of drugs that help them calm down. All right, so let's see the diagnostic criteria for both of these disorders. So for bipolar 1 disorder, it is necessary to meet the criteria for a manic episode. The manic episode may have been preceded by and may be followed by hypomanic or major depressive episode. So once that your client has a manic episode, that's bipolar 1, regardless if he already had or not a depressive episode or hypomanic episode. It's likely that they have experienced something similar, but it's not mandatory for the diagnosis, okay? Just the manic episode is what you are looking. If they have it, it's bipolar 1. So criteria A have been met for at least one manic episode. Criteria B, the occurrence of the manic and major depressive episode is not better explained by schizoaffective disorder, schizophrenia, schizophreniform disorder, delusional disorder, or other specified or unspecified schizophrenia spectrum and other psychotic disorder. What does this mean? These clients are not psychotic. They can have psychotic symptoms, but they don't have a psychotic disorder. This is a mood disorder. This bipolar disorder is a fluctuation in their mood. They go either from depression or hypomanic to manic. But that's the characteristic. The main characteristic is not the psychotic symptoms. Now, it's necessary to specify if the manic episode or the depressive episode were mild, moderate, severe, or with psychotic features. So you can have clients, as I was telling you before, that they are in mania and they may have delusional thinking and hallucinations. But the same can be true when they are in depression. But you can have other clients that they don't have any of those symptoms, psychotic symptoms. They are just having manic episodes without psychotic symptoms or depressive episodes without psychotic symptoms, okay? That's why you need to identify these 4 possibilities. The prevalence, in a 12-month prevalence estimated in the United States, 0.6% for bipolar 1 disorder, okay? So this is not a very prevalent disorder. You are not gonna see it very often. However, something that it's important to have in mind is that some authors are talking about bipolar 3 disorder, which in reality is not bipolar 3, but is bipolar 1 due to substance abuse. And that's when you can see an increase of prevalence of our clients having this type of disorders. We are seeing an increase of people consuming substances from marijuana to LSD and heroin. And it's important to have in mind, guys, that some of the side effects of these drugs, it's activating bipolar disorder-like disorders. And that's true also for marijuana. People are thinking of marijuana as a unharmful drug, and that's not the case. Marijuana is correlated with manic episodes. And I have seen many of my clients with that characteristic. They were not bipolar, like clear bipolar per se, but they develop bipolarity as a side effect of their substance abuse disorder, okay? And the lifetime male to female prevalence ratio is approximately 1.1 to 1. So this is not as different as in depression or as in anxiety, where women have a higher risk of developing those disorders. Now, why is this happening? Well, environmental issues. High versus low income countries. This is very interesting. It's more frequent in high income countries than low income countries. And that's saying something. I don't know how to interpret this. Maybe it's because in high income countries are using more drugs. Maybe it's because there's more divorce and therefore more fatherless environments, and that has been correlated with many mental health problems. I don't know, maybe it's because in high income countries, there's also a decline of religiosity. But there's a correlation there. And again, people who come from families that they were separate, divorced, also widows, or that they were not married. So single parent families. Genetic and physiological issues. So again, for depression, bipolarity, and schizophrenia, we have genetic evidence that says that up to 40% of the disorder might be explained by genetic components, okay? And in the case of bipolarity, if you have a relative with bipolarity 1 or bipolarity 2, your chances increase 10 times, all right? And you can see there's a shared genetic origin with schizophrenia. Course modifiers. So manic episodes with psychotic futures plus psychotic futures in the future, which this means is that if you have a client that has bipolar 1 and also has psychotic symptoms, the prognosis is going to be very challenging. And it's more likely that you're going to work with this client, not with the idea that they're going to get cured, but with the idea that they need to be in control of the disorder. And I will say that's a general suggestion that I will give you guys. When you have a bipolar 1, you don't want to talk about cure with them, but you want to talk about getting control of their disorder. How are they going to get control of their disorder? Well, getting in control of their medication, of their psychotherapy, and their lifestyle. Those 3 things can help them to reduce the frequency and the intensity of the manic episodes and the depressive episodes as well. Make sense, guys?
Yeah, I have a question, if that's okay.
Yeah, absolutely.
As far as when it's related to substance abuse, like how, I mean, obviously you would have to, from a counseling perspective, come from, acknowledging and treating the substance abuse along with the bipolar disorder. But I don't even know what my question is. It's gone. It was something related to how to treat somebody who has bipolar disorder as a result of substance use. That's all I know, but I don't remember what it was.
That's okay. I had a client. I don't know if I have it here. Well, yeah, I had this client. Okay, she had a 21 years old, an absent father, living in 4 different countries, lack of peer group of relationships, substance abuser since the age of 14, constant marijuana user, poor family relationship, right? And she was denying that she was having any problems with the marijuana. Marijuana is healthy, it's natural. That's why it's becoming legal everywhere. You're old school, Mario, you don't understand. And I was like, okay. It didn't matter all the amount of research that I was providing to her. She was resistant, reluctant. And I'm like, oh, this is weird, right? She's very attached to her marijuana problem. But suddenly she started having symptoms. First, insomnia, Allison. She stopped sleeping for days and days and days. Then she started having depressed mood. Then she started having lack of interest, feeling of worthless. lack of social life, inadequacy feelings, then social anxiety. And then she had the first manic episode at my office. And I was completely scared when I saw that because I'm used to see this girl thinking that her whole problem was substance abuse alone. And then I'm having her in front of me. She's not high and she's having manic episode. And she's telling me, I feel awesome. I finally understood what you have been saying about life. And now I want to live my life to the maximum. And because of that, I have been enjoying myself a lot. So I have been seeing some people. Well, actually not seeing them. I met them in the bar, right? But then we had a great time. And I want to tell you that something very interesting happened to me. I have been having sex with this very famous person. And I'm like, where is all this coming from, right? So I was really concerned about her. And I started asking her, have you been sleeping? No, but I don't need to sleep. I feel so well that I just realized that I don't need to sleep. How long have you been without sleeping? For 4 days in a row. Okay. What do you think about all this energy that you are experimenting? It's awesome, Mario. It's awesome. And how would you describe your mood? I'm super happy, she was telling me. And I'm like, okay, I'm concerned about you. Have you ever felt it this way? Why is it you are concerned about me? She was telling me. You have been telling me all these things about happiness and enjoying life, and now you are concerned about me? I don't understand you. So I was very clear with her, and I say, I think that you are in a manic episode, and we need to take care of yourself. You are wrong, I am not, and this and that. So I made the decision and I made the call to the father, and I said to the father, I think your daughter is in a manic episode. You should come for her and you should take care of her and maybe bring her to the hospital. So at least to be sure that this is not a manic episode, because if it is a manic episode, she can be on risk and put on others at risk. And the father resisted, and the father said like, no, she's okay. I take full responsibility. And I was like, okay, it's up to you now. 2 days later, the father called me and he was completely freaking out. What's wrong with my daughter? I don't know what's going on. She's violent. She's hitting me. She's accusing me of things that I have never done to her. The police was here. She was violent with the police too. She has been violent with the neighbors. What's going on? I say, she's in a manic episode. I told you. You have to take her to the hospital. So after that, they asked me my opinion, and they say like, is she bipolar? And I say, well, she has bipolar symptoms, but she never had them before. And we don't know if it's because of the drug or because she really has bipolarity regardless the drug. So what are we gonna do? Well, what we did, Allison, is that we work with both things at the same time. She started receiving consultation from a psychiatrist whom started giving her medicine for the bipolarity. And she started attending group meetings for substance abuse problems. And she continued with her personal therapy with me. So we were working in group, and it was not easy. It took us years and years of work, but I can tell you that now she has graduated from college. She has a much more stable life. She has not had any other manic episodes. She's not consuming drugs. She's still taking medicines, but she has a life back. So answering your question, you have to address both, okay? All right, so this is a perspective of bipolar patient.
Somebody can point to a broken ankle on an x-ray machine and say that's what's wrong. When it's happening inside your mind, it feels like it's not a real thing. And I think that that's where a lot of the stigmas come from.
I'm bipolar.
I am bipolar.
I'm bipolar, but I'm not a ticking time bomb.
We're not all depressed.
But I'm not just gonna snap out of it through positive thinking. I'm bipolar.
Bipolar.
But I'm not unpredictable.
I'm not fragile or delicate.
I'm bipolar,
But I'm not a zombie.
I don't attract chaos.
I don't define myself by an illness.
I'm bipolar, but I'm not a drug addict.
Just because someone is on medication doesn't mean that they are a drug addict.
We all experience emotions.
I'm not off my meds just because I'm emotional.
And I'm not trying to be trendy with my cool mental illness.
But I am not your manic pixie dream girl. But I'm not looking for attention. I am not a victim of my emotions. If you feel like you can't deal with things on your own, it can be as easy as talking to somebody about it.
I promise you that when you speak and ask for help and talk about it, you will realize that you are not the only person dealing with this. I didn't give up.
You are stronger than you think you are.
Self-care is not selfish. You are not alone. I have bipolar disorder, but I'm not weak or using it as a cop-out to not live life. I live life large.
I am a dad, a husband, and a family man.
I am capable of having a long-term relationship. I've had a lot of relationships, like a lot.
I'm bipolar, and I'm a vegan, and I'm a cat mom.
Making people laugh and laughing is my favorite thing.
I am an advocate for mental illness and for equality for everyone.
And I'm great with kids. I'm a nanny and a camp counselor, and I rock it. I'm single.
I am a veteran. I believe in serving people and helping people.
I'm a feminist. I lead a completely normal life. I'm a human being. We're all human beings. I'm human, like you.
I have bipolar disorder, and
I am happy with who I am.
it is so not who I am. It's just a part of who I am. And I'd say that I am pretty happy.
All right. So one of the things that I think that it's very interesting is that people can identify with their disorders. They can build their identity on the disorders that they have. So people say things like, I am bipolar, or I am schizophrenic, or I am depressive, a depressive person, or depressed, or I'm an anxious person, right? But people don't say, I am a diarrhea, or I am a cold, or I am COVID. No, people say, I have COVID, I have diarrhea. This is interesting, guys, and at the same time, it's important to address with our clients, because if you build your identity based on your disorder, then you have a problem. You cannot change what you are. So I cannot change that I am a human being, even though I would like to be a dog, or I would like to be an eagle, right? A cat is a cat, a dog is a dog. If you say, I'm bipolar, well, then you are cursed, you are doomed. There's nothing that you can do because you cannot change what you are. But if you say, I have bipolarity, I have depression, I have schizophrenia, then you are more than your illness, you are more than your disorder, and then you can do something for that. And perhaps one day you have depression, and perhaps someday you will not have depression. In the case of bipolarity, you have symptoms, and if you work with that, perhaps you can be symptom-free. That's why I really like this video, because it's telling us that we need to be careful labeling our clients and avoiding that they identify with the disorder as if the disorder is their identity. It is not, it cannot be. Otherwise, they are not gonna get better, okay? I'm promoting this idea of, if you have a disorder or if you have symptoms, then we have something to do. And what we're gonna do is, how can we improve your mental health? How can we decrease those symptoms or get rid of them if it's possible, in a way that it's positive for you, okay? Make sense what I'm saying, guys?
I have another question.
Yeah, go ahead.
When it comes to both having someone understand their disorder, but then also not being caught up in it, right? Like as that full identity factor, how, like, I don't know, maybe from your own experience you can share, like, how do you do that? Like, how do you tell somebody to not fully identify with their disorder, I guess, without sounding like an a-hole? Because that, I feel like that could easily happen.
Yeah. So, for example, if someone says to me, I am bipolar, I will ask directly, are you bipolar or do you have bipolarity? Just asking that question, it makes them think about what's going on with them. And then if they say, well, I am bipolar, I say, that's okay. Thinking that you are bipolar, is that helpful for you? Does that make you be more in control of the situation or not? What if you think that you have bipolarity, that you are not bipolar, but that you have bipolarity? Will that be more helpful? Will that give you a sense of more control of the situation? And I use the example of the diarrhea with them. I say to them, when you have diarrhea, do you say that I am diarrhea? Or do you say I have diarrhea? And they are like, of course, I have diarrhea. Then if you have diarrhea, what do you have to do? Well, I have to take my medicines and I have to take care of myself for some days until the diarrhea is gone. What if you see this in the same way? You have symptoms and you need to take care of them with your medicines, with your treatment, and with your lifestyle. Wouldn't that be more productive for you, more useful? Most clients say yes. But if there's a client that is resisting, I'm not going to fight about that with them. I'm going to let them, and I'm going to say, okay, if you want to see yourself as a bipolarity, I guess that it's okay for you. But I would just encourage you to have in mind if that is really helpful for you or not, because what I see is that beside your bipolarity, you are also a student, you are also a daughter, you are also a friend, you are also a Christian, you are also this and this and that. And all those things are part of who you are. Don't you think so? So that's how I handle this.
Thank you. I guess I was just asking because I think it's a very prevalent thing for young people right now. It's very, like, a really big thing to completely identify with your disorder. So just wondering.
And that says a lot about our society, right? Or kids or the young generation, they are looking for something that help them to feel that they belong, that they are part of a group. And why is that they are looking so desperately in mental disorders to be part of the group? Well, perhaps because as a society, we have to change things. Families under a crisis, or society is under a crisis, and people are feeling detached, disconnected. All right, so medications. Mood stabilizing medications are the backbone of the treatment. If you have a client with bipolar 1 and he's not under medication, he can be in troubles, and you as well, guys, okay? There are 3 different categories. Lithium is pretty much 80% of the clients are using them. Anti-epileptic agents and second generation of antipsychotics, okay? But the response rate is 50%. So with this, again, medicine is not the magic pill, it's not the solution. You need to integrate psychotherapy with the medicine. And guess what? If they receive electrotherapy, right? If they receive electrotherapy, the response rate goes up to 75%. So one day I asked to one of a friend of that I have, a psychiatrist, I say to him, why is that if you provide electrotherapy to these clients, they have 75% of chances of recovering, and medicine only 50%? Why is that you are not using electrotherapy more often? Because you need to have in mind, guys, that electrotherapy is not as in the Jack Nicholson movie. They are asleep, they use them. The only side effect that they have is headaches. some amnesia, but suddenly, but it's they recover the memory after one day, and it's just minor amnesia, minor things, okay? And he answered back and said, like, well, because it's not as profitable as the drugs. With the drugs, the big pharmas are selling more, and we see the clients more often than with electrotherapy. And I thought, like, okay, fair enough. You were honest with me. Okay, that was his opinion. All right, so what's the difference between bipolar 1 and bipolar 2? We already said that, right? It's the hypomanic episode. So the criteria A have been met for at least one hypomanic episode and at least one major depressive episode. So here, depressive episode, it's mandatory to provide a diagnostic. In bipolar 1, no, it's optional. If the person might or might not have a depressive episode. But here you need a depressive episode and hypomanic episode to diagnose bipolar 2. Why is that? Well, because if it's only a hypomanic episode and no depressive, it might be other thing. It might be, again, substance, or it might be just that the person was very excited and lose control for other reasons, maybe lack of sleep and things like that. But when you have both, then it's more likely that it's bipolarity, okay? And criteria B has never been a manic episode. Keep that in mind, guys. As soon as there's a manic episode, that is bipolarity 1, okay? Okay, all the other information is pretty much the same. And yeah, that's depression and bipolarity. And I said to you that there's another disorder that it's called cyclothymia, and which is like a light version of bipolarity. People don't have a full depressive episode, neither a manic episode or hypomanic episode, but they have swings between feeling depressed and feeling euphoric. So is that people that you say, like, one day you talk with him and he's pessimistic, and next day you talk with him and he's optimistic. And it's like a personality pattern. It's the way of being of the person. So there's a lot of debate on that disorder. Authors saying that we should get rid of that disorder because they say that it's more a personality thing than a mood disorder. All right? Questions about this? No? All right. So let's go with psychotic disorders, guys. These are very important disorders, extremely severe disorders, and they make the life of the clients and the family, the relatives, very challenging, debilitating, okay? So let's talk about it. These are the topics that we're gonna see: the diathesis stress model, the nature of psychotic symptoms, schizophrenia spectrum disorders, the course of symptoms, treatment, and there's a film. We will not have time to watch it, but I strongly suggest you go and watch it. It's a 30 minutes long film. It's a very good film with real people experimenting psychosis. So what is this diathesis stress model? Well, it's a model that we use in psychopathology to explain why people get disorders. And this is especially true in psychosis. The perspective that psychopathology is caused by a combination of genetically inherited biological diathesis, which means a biological predisposition, and environmental stress. This is what I was telling you guys. It's not enough that a person has a genetic predisposition. They need circumstances, experiences in life to get that activated. And the opposite is also true. You might have that genetic predisposition, but the circumstances and experiences in your life were so positive that you are silencing that genetic disposition. So what are those environmental factors and experiences? Well, trauma, for sure. We know that people who experience physical violence, sexual violence, and so on, they are much more vulnerable. Attachment problems. If you had a bad relationship with mom and with dad, or with both of them, in your childhood, if they didn't attend you, if they didn't provide the needs that you require, that's a problem. Substance, it's another environmental stress or environmental element that can activate these biological predispositions, alcohol, drugs, and so on. Isolation, that's a very important, because we don't talk enough about that. But we live in these big cities and people are struggling with isolation. And that's very detrimental for mental health as well. And physical challenges, okay? So physical disabilities, physical illness, and of course, I'm forgetting poverty. Poverty is a really, really bad thing for the mental health. So if you are born in a positive environment with mom and dad, it's a good neighborhood, you have a good social life, of course you have problems, nobody's perfect, but you don't mess too much with drugs, alcohol, you don't have traumatic events, and so on, well, it's unlikely that you're going to develop mental disorders, and especially psychosis, even if you have that biological predisposition. Okay? So that's the diathesis stress model, and we try to use that to explain, because as I was telling you, for disorders such as depression, bipolarity, and schizophrenia, that we have evidence of this biological predisposition, it's only 40% of it. Only 40%. You cannot explain all of it, okay? All right, so when you're talking about psychotic symptoms, you need to have in mind that there are two different levels of psychotic symptoms, okay? One is the positive symptoms. This is not that they are good, but they represent an increase of the activity in the person. And these are the four groups of positive symptoms: delusions, hallucinations, disorganized thinking, and grossly disorganized or abnormal motor, okay? What are delusions? Are ideas that are not based on reality. And the content of those ideas are persecutory. Someone wants to harm me, someone wants to, there's a complot, there's a plot against me, right? Grandiose ideas. I'm very famous, I'm a very important person. The president is talking to me every day, and he is taking my advice because I'm so important person. Of control, this is very interesting. Someone is controlling my thoughts. Someone is controlling my behavior. Aliens are controlling what I am thinking. Aliens are controlling everything that I'm doing. You know what? Actually, I have a device in my brain, and with that device, they are controlling everything that I say, everything that I do, okay? Of reference, these are similar to the persecutory, but are more in the sense that things that happen in the outside is because I am provoking them. So for example, all the crisis going on in the election is because of me. I did something that is provoking all this. It's my fault that this is happening. Or there's an earthquake, and that earthquake happened because I was thinking in an earthquake. So I caused the earthquake. Nihilistic, these are where they have this type of delusions where they are talking in a very mystical way, emptiness, and erotomaniac delusions. So this is related with sex, right? And these are most common with the idea that famous, important people find the client so attractive that they cannot control, and that they are having sex with the client all the time. And so these are the delusions that you're gonna see with these clients. Now, Olivia in one of the class was saying, like, how am I gonna judge that is right or wrong if I also have beliefs about God, angels, and demons, and so on. Well, when you are talking with a delusional person, it's very evident that they are out of control and the ideas are completely impossible. Okay, it's not that these are ideas. For example, in the persecutory delusions, these are not what's the word that I'm looking here. I just forgot what I was trying to say. Okay, well, you will see. It's very evident what they are saying. It's very, very unlikely that it's possible in reality. It's so extreme the way that they are saying things and thinking things that it's evident that something is wrong with them, okay? Hallucinations. We have 4 different types of hallucinations. Auditory, most likely voices, okay? Other can be also music or noise or other type of sounds. Olfactory, they smell, and generally speaking, they smell like, sorry for the word, but like poop, right? Like smells like poop, smells very bad. Gustatory, they have a taste of something that doesn't exist. And tactile, like they are experimenting, like if something or someone is touching them. Then you have disorganized thinking. So derailment. This means that they are going from one topic to other. So for example, they start talking to you about, yes, I was in my work and I was paying attention to what my boss was doing. And then you know what happened with that soccer player? It's very interesting because he was playing soccer and now he's not playing soccer. Yeah. But also, did you see what happened with Biden? He was accused of this thing about his laptop and yeah. Oh, by the way, have you noticed that Jesus Christ died for us? So he's just moving from one topic to other topic with no connection at all. Loose association. This is when they are, how should I explain this? They are losing association with the things that they are talking, not in the way that they are moving from one topic or the other, but then suddenly they don't follow the conversation, okay? You are talking with them and they stop following the conversation. Tangentiality, this is that they are giving very tangential answers, tangent answers. So you're asking for something and the most they say, yes, no, I don't know. Or they answer with something that it's not meaningful or important for the conversation. Clanging, I don't know how to explain clanging. I'm gonna move to neologism, guys. They build new words that they don't exist, okay? So they can come with words that, yes, I was in my room and I was doing frolicking, and then I realized that someone was paying attention to me. What were you doing? Frolicking. Sorry, what? Frolicking. What is that? Oh, you don't know what is frolicking? So they are building, making up words. Word salads. This is when they are talking and it's completely incoherent. So you are trying to establish a conversation with them and they say like the phone and the watch and the pen and the car and the astronaut and then the dog and then the letter and then the student, right? And poverty of content. This is just that they don't have nothing to share. They can be mute, they can be silenced. You ask questions and they don't answer back, okay? And the final positive symptom is grossly disorganized or abnormal motor. There's 2 types of these guys. One is inappropriate. They can dress very extravagant. They can dress in ways that are not appropriate at all, not only because of what people are going to say, but because weather, for example, winter, and they go out in swimming suit and that's it, nothing else. Or summer and they come out with a winter jacket, gloves, things like that. Or the inappropriate behavior can be that suddenly they are in a mall and they take their pants off and they start peeing in the mall in front of everybody. Or they can start masturbating in a public place, okay? And catatonic, this is when they are completely paralyzed, like status, okay? And they are rigid and they can stay like that for hours and even days. And if you try to move them, you cannot. And they have no interaction with the outside world. You talk to them and they don't respond. You can even harm them and seems that they are not feeling anything at all. It's very, very, very sad to see a person in a catatonic stage, guys. So those are the positive symptoms, guys, okay? Now, as you can see, they are not positive in the sense of good. There's nothing good about these symptoms. Now let's talk about the negative symptoms, and then I'm going to ask you if you have any questions about all this. Diminished emotional expression. They don't express emotions. Affective flattering. Seems that they cannot feel neither sad or happy. They are flat. Avolition. That means that they stop doing things, like they are not active. They are very passive. Alogia, that means that they don't express too much. They are pretty much silent all the time. Anedonia, as in the depression, they don't enjoy what they do. And asociality, they detach from people. They don't want to be with people. Now, when are you going to see the positive and the negative symptoms? Most part of the time, the negative symptoms are present before the positive symptoms and after the positive symptoms. And because they are present before the positive symptoms, many of these clients, they receive the diagnosis of depression. Because think about these negative symptoms. They look very much like depression, right? But it is not depression. It is the mind losing little by little contact with reality. And they start having all these symptoms, and then they have a full psychotic break. That's when you see the positive symptoms, okay? And when they get out of those positive symptoms, you're gonna see again the negative symptoms. If they receive appropriate treatment, then they're gonna go to a stage of stability and functionality. All right, it's a lot of information, so I want to ask you, is this clear? Questions, doubts? Guys, is everything clear so far?
Yeah.
Okay, so you are going to diagnose someone with a specific psychotic disorder when they have positive symptoms. But be careful, because you can think that someone is depressive, but in reality it's these negative symptoms, and then they're going to show positive symptoms.
So wait. So, well, that freaks me out. I don't want to freaking diagnose with somebody with depression. Next thing I know, they're catatonic in a hospital. Like,
yeah.
So how do you determine, because I'm reading the list for the negative symptoms and I'm like, okay, like to me that is depression. So like, how do you just wait till they start getting toward the cusp of the positive symptoms in order to tell?
I'm gonna say you a clue, and that is you look for strange content in their thinking. Once that they are in the negative symptoms, they start having strange content in their thinking. They start talking about angels, about UFOs, about aliens, about weird things that many people talk about them, right? But they don't have these symptoms. And most of the depressive clients, they don't have that strange content. And then at the same time, you start looking for strange behavior. Suddenly, they start behaving more isolated, and they start behaving in ways that are not normal, dressing in ways that are not normal. You start seeing those things, okay? Unfortunately, there can be up to 5 years period between they start developing the negative symptoms and they have the positive symptoms. And that's why it's so common that they receive a diagnosis of depression, bipolarity, or even personality disorders. Because yes, unfortunately, until they don't have a full psychotic breakdown, we cannot be for sure, Alison.
So couldn't you just say that, I mean, for all we know, they really do have major depressive disorder, and then as a result of having that for so long, had a psychotic break?
Yes. Yes, what you want to do there is that you want to corroborate your diagnosis, right? And if you think that it's not depression anymore, but it's a psychotic disorder, then you're going to change your diagnosis. It's very sad because the longer that you have the right diagnosis, the longer they're going to start receiving the appropriate medicine and treatment. And that reduces the chances of getting better. And at the same time, every time that they have a psychotic breakdown, they have brain damage. That's why once that they had their first psychotic breakdown, you don't want to have these patients without medicine, guys. They are in risk of brain damage if they have more psychotic breakdowns. And of course, they put themselves in risk and other people in risk too, okay? Has any of you started watching the show that I suggest to you or not? You have to watch.
I finished it.
Really? Oh.
Yes, it's so good.
It's awesome,
Yeah,
right,
I
Ashley?
started.
It's so good.
Yeah, I like it. I really like it. I couldn't sleep, so I watched like an episode and a half.
Did you, when I was walking you through the symptoms of the positive symptoms, did you see some of the symptoms in the character?
Oh, yeah.
It's
100%.
psychotic episodes. I only watched like maybe 45 minutes of the first one.
Oh, it's the first one is so intense, right?
Yeah.
Guys, the rest of you go and watch the series. It's very eye-opening for what is a psychotic disorder, for how the relatives deal with that, and the work that we have to do as a counselors.
What's it called again?
I know this much is true.
Yeah. Thank you.
Very good. All right. So these are the disorders that we need to study. Delusional disorder, brief psychotic disorder, schizophrenia, and schizoaffective disorder. So let's go with them. The delusional
I have one quick question before we go on to this.
Yes,
so you were saying before that you have to get someone on medication if they're, having these episodes and stuff. So because obviously we can't give them medicine, so we would refer them to a doctor, would they still technically be our client, or would they not be our client anymore because of the medication transfer?
They are still your clients. You're gonna refer them with a psychiatrist, and you want to be in touch with the psychiatrist, okay? This is not a family doctor. This is not a pediatrician. It's a psychiatrist, very severe disorders and very powerful medicines. So you want to ask your client or the relative of your client to sign a release information letter so you can contact the psychiatrist and work together. Some psychiatrists, they resist. Psychiatrists are very peculiar animals. You will see that. Not all of them, but some of them, right? But the goal is be in communication with the psychiatrist, be in communication with the family, and build a team together. All the strategies, all of them need to be in the same place, understand what are we doing, how are we working. Now with the medicines, you can see peculiar symptoms too. So if the psychiatrist is not explaining you that, the client can come to your meeting and say, I'm feeling this, I'm having this, and you can be thinking, oh, he might have another psychotic breakdown, or he might go to negative symptoms, and perhaps it's the side effects of the medicine. So yeah, I need to be honest with you. It's not easy to get along with psychiatrists, and not all of them see us with good eyes. Okay, they think that we are doing their job and that we are a competition for them. The reality is that most of the psychiatrists, they don't know how to provide counseling, psychotherapy, because their training most part of the time is based only in drugs, medicines. So yeah, anyway. So the delusional disorder, the main characteristic of this particular disorder are delusions, not necessarily hallucinations, okay? So criteria A, the presence of one or more delusions with a duration of 1 month or longer. This is important, guys. These clients, they are not having hallucinations, they are having delusions, okay? That's why it says criterion A for schizophrenia has never been met, because that's the hallucinations, all right? So apart from the impact of the delusions or its ramifications, functioning is not markedly impaired and behavior is not obviously bizarre or odd. So they have weird ideas, but they can function because they don't have hallucinations. Once that you start having hallucinations, it's very difficult for you to function in society, okay? If manic or major depressive episodes have occurred, these have been brief relative to the duration of the delusional periods. And the disturbance is not because they have an illness or substance disorder, okay? Now, these are the type of delusions that they can have. Erotomaniac type, we already talked about them. Grandiose type, we already talked about that. Jealous type. I just watch a very, not all jealous people are wrong, guys. Not all jealous people are delusional. Huh? You need to have that in mind. There are cheaters out there.
Who hurt you, Dr. Guzman?
No, they did not hurt me. I watched a video that was so hilarious. There's this guy coming to visit his girlfriend. He has flowers in his hand. And suddenly he realized that the girlfriend is cheating him. And this is a building. And the girlfriend goes to receive him in the first floor. And you can see the lover in the second floor. And there's a person recording everything. And this guy is becoming crazy. And the lady, she's in a towel. She's naked, but she's in a towel. And she's denying the situation. So the guy is becoming crazy, right? And he's trying to go upstairs and she's stopping him. And you can see the lover trying to sneaky to leave the place. So when he's going up, the lover, he jumps from the first floor to the main floor. And anyways, ridiculous. But he's in underwear. So all this seems like a movie, but it was a real event in life and someone recorded and they uploaded to social media. So poor people, because now everybody is seeing them. Everybody knows that she's a cheater, that this guy they were fooling him, and now they know who's the lover, and he's in underwear. It was crazy. So, all right. Anyway, I'm gonna share that with you.
We don't care if they get exposed. We're more concerned about the poor guy that got caught in the middle of it.
Yeah, poor guy. He was becoming crazy. He was like out of control. All right. So persecutory type, we already talked about that. Somatic type. This involve bodily functions or sensations. This is important, guys, because suddenly they say something like, you know what? There's something wrong with my stomach. And there's something wrong, and because there's something wrong, they can harm themselves because they think that there's something wrong with their stomach or with their leg or with their hands or whatever. Okay, and then there's the mixed type when they have all these different ideas going on. Okay, so that's the delusional disorder. Just have in mind, guys, the main symptom here are delusions, not hallucinations, okay? Brief psychotic disorder. Here, you're gonna have the whole positive symptoms, these ones, okay? But it's gonna be in a very brief period of time, okay? The presence of one or more of the positive symptoms, but the duration of an episode of disturbance is at least 1 day, but less than 1 month, with eventual full return to premorbid level of functioning. So these are people that they seem very normal people, and suddenly, with no negative symptoms, they develop the positive symptoms. Why is that? Most part of the time is because they are sleep deprived. If you stop sleeping for 5 days or 1 week, you're gonna have a whole psychotic breakdown, guys, okay? Number 2, because they have been using substances. And number 3, because they might have experienced a very severe traumatic event. And psychosis is working as a self-mechanism to protect them from that distress, okay? All right. And finally, schizophrenia. This is the most important of all of them. It's the more debilitating of all of them. And it's really important that you can understand them. Because if you ever see a client with schizophrenia, you need to work with them in collaboration with a psychiatrist, and you need to be clear of what is this, okay? So criteria A, you see all the positive symptoms plus negative symptoms, okay? Remember that I say they are generally before and after the positive symptoms, okay? And see, it says at least one of these symptoms needs to be either 1 or 3, which means delusions and disorganized speech, okay? Criteria B, 1 or more major areas functioning, such as work, interpersonal relationships, are markedly below the level achieved prior to the onset. The life of people with schizophrenia can be very negative. Continuous signs of the disturbance persist for at least 6 months. Once that you get schizophrenia, there's no cure for schizophrenia, okay? With the medicines, with the therapy, with the support of your family, you can have a highly functional life. Actually, there's a very famous psychology professor in Canada that he has schizophrenia. And yeah. Criterion D, schizoaffective disorder and depressive and bipolar disorder with psychotic features have been ruled out. You're gonna be like, what is that psychoaffective disorder? Well, it's schizophrenia plus depression. It's more challenging, right, Alison? I know, it's confusing and challenging, but we will see. Substance and medical conditions are excluded. If there's a history of autism spectrum disorder or other communication disorder of childhood onset, the additional diagnosis of schizophrenia is made only if prominent delusions or hallucinations are also present for at least 1 month. It's not easy, guys, and I understand, but you are gonna develop clinical judgment. That's why the more that you can read, the more that you can watch such as the shows that I was suggesting to you, or the film that I have for you, the better, because little by little, these things are going to start making sense. Autism is a very debilitating disorder as well. But the difference is that you are autistic. Sorry, you have autism since childhood, and you have autism your whole life. Schizophrenia is not like that. Schizophrenia, generally speaking, you start having negative symptoms in adolescence around the age of 15 or 17. And then you have psychotic symptoms around the age of 20, okay? Autism is since you are little. So that's why they are saying, if there's an autism disorder, for you to give the diagnosis of schizophrenia, it needs to be a month with hallucinations and delusions. So you can see that it's a completely different thing than the autism. And these are the subtypes of schizophrenia. So we have paranoid type. Here, the delusions and hallucinations are regarding about someone trying to cause harm to the person, okay? There's people following me, there's people that they want to kill me, there's people that they are behind me, and the hallucinations, there's more likely auditory hallucinations. It's about voices telling him things. The guy in the show, he has paranoid schizophrenia, okay? Catatonic, I already explained that. It's the schizophrenia where they have that catatonic episodes. You cannot move them. They are like status. Very, very difficult to see them. Simple type, absence of prominent delusions, hallucinations, disorganized speech, and grossly disorganized or catatonic behavior. What does that mean? They still have them, but they are not as severe, okay? And disorganized type. All of the following are prominent. All these disorganized speech, disorganized behavior, flat or inappropriate affect, are present and are important, okay? These are the types of schizophrenias that we have. And this is the schizoaffective disorder, to make things more complicated. The criteria A is an uninterrupted period of illness during which at some time there is either a major depressive disorder or manic episode or a mix of both, concurrent with symptoms of schizophrenia. So this is people with schizophrenia that they have a major depressive disorder or a manic episode or both of them at the same time. But the main characteristic, still schizophrenia, guys. All right. So 5 minutes and we are stopping, okay? These are the 3 stages. I already say to you, there are negative symptoms, positive symptoms. And I say to you, negative symptoms, they are usually before and after the positive symptoms. Well, that is called prodromal stage. And as I say to you, it can be a period of time of 5 years where the person is little by little going down with the negative symptoms before they have the positive symptoms, the psychotic breakdown, okay? Can be up to 5 years. Then the active stage is when they have all the positive symptoms. And this can be matter of a month, matter of more time, matter of days, because it's gonna depend if he's admitted or not to the hospital. But once that they have the positive symptoms, they need to go to the hospital. They need to start receiving the medicines. Otherwise, they are not gonna improve, okay? And then once that the positive symptoms are going down, they're gonna have again negative symptoms, and we call that residual stage, okay? So prodromal stage, it's like it's building up the psychosis, it's preparing the psychosis. the active stage, the full psychotic symptoms, then the residual stage, the person doesn't have positive symptoms anymore, but he has negative symptoms. It goes like this, okay? All right. The treatments, neuroleptics or antipsychotic medicines, first generation of antipsychotic drugs, then there's second generation antipsychotic drugs, but they have a problem, guys, and that are called extrapyramidal side effects. They start shaking, they start walking as a robot, they cannot close their mouth, the saliva comes out of the mouth, and then these are long time side effects. There are medicines that can help to decrease those side effects, but not 100%. And it's very sad to see them. Actually, in the show, that's one of the things that the brother is complaining, right, guys? He's saying like, I don't want that you increase the medicine because he becomes like a robot. He becomes like an empty soul. And yes, that's true. But then if you have the appropriate doses and the appropriate therapy, they can be functional. And yeah, the higher the dose, the more severe side effects they're gonna have. And there's a specific type of CBT that it's CBTP, cognitive behavioral therapy for psychosis. And these are the 6 things that we do with these clients. When they are in the positive symptoms, and even when they are not, we help them to challenge the delusional beliefs, that they can realize that that way of thinking is not real, it's not rational, it's a delusion. Then when they, we help them to see that the meaning that they are placing to their hallucinations is not real. So, for example, when they say that there's someone telling me that I am impure and then I have to cut a part of my body, or I have to do a sacrifice in order to be pure, right? Well, you need to work with that and you need to help them to see that the meaning is not real, that is the content of a hallucination, but there's no.
Sorry,
yes.
I have a question. But that doesn't make sense to me, because if they're not able to make that connection, if they're not cognitively able to do that, I mean, couldn't you just end up sitting there and arguing with them for 30 minutes? I mean, that to me just seems.
Yes.
Can't you work with them within their subjective understanding of what's going on around them, or is that not a good idea?
That's a very fair question. When they are in the most active stage, it's very difficult to do it. Very, or I would say almost impossible. But once that they start taking the medicines and that the symptoms start going down, then you can work with them. And even when they are in the negative symptoms, they are not psychotic anymore, they are having the negative symptoms, but they're still believing what the experience that they had. And then that's when you have to challenge them too, to see, okay, let's talk about what are the delusions, what are the hallucinations. You need to work with psychoeducation with them. You need to explain them what are those, and little by little helping them to see that those hallucinations and delusions are not real. And it's very interesting because they can start having a dialogue with that. There's a very effective type of therapy that was developed in Finland after World War II, because there was a massive number of people having psychotic disorders after war, and they were really poor. And they call it oh my God, I just forgot the name of it.
If you don't remember, I did write it down, so I can probably look it up.
Yeah, I'm gonna share with you a podcast, okay? This open dialogue therapy. What they do is that they teach the patients to openly establish a dialogue with their hallucinations and their delusional beliefs. And it's very effective. So yeah, reattribution therapy is similar to that. We help them to find a different explanation of the things that they are saying to themselves. Another goal is to reduce the negative symptoms by challenging them to their low expectations. So helping them to have a schedule, to have a routine, to have an active life. Help to adjust to the reality outside world after hospitalization is not easy for them. So we need to help them and help the family, and helping the adherence with the medicine. So those are the goals. And again, there's no cure, but they can learn to control their disorder. Personal therapy, family intervention. I'm going to skip this, guys. You can read it. But basically, what we are working in the personal therapy is, well, I'm going to go fast with this. Learning to identify signs of relapse. So before they get the full psychotic breakdown, that they can realize, I'm thinking weird again, I'm behaving weird again. What do I have to do? Relaxation techniques that help to deal with the stress, anxiety, adaptive response, a lot of social skills for these people. Yes, and the family. If you don't work with the family, you decrease the chances that they get better. So a lot of psychoeducation, a lot of working on how are they dealing and feeling with the situation. It's very devastating for the family. So they need to work a lot with assertive strategies, conflict resolution strategies, and so on. All right, we're gonna stop there, guys. Please go and watch the film. I really would like to have a conversation with you next week about the film, so you can share with me your thoughts about it, okay? It's 30 minutes long. It's a documentary. All right. Questions, doubts, comments?
The film is on Bright Space, right? You're not talking about the movie, correct?
Sorry?
The documentary you're talking about is on Bright Space, not the movie, the episodes, right?
It's in the, in the PPT, you're gonna see the link to the documentary that I'm telling you.
Oh, okay.
And it's the very last slide of the PPT. And then the show that we were talking.
Yeah, I watched that. I started that. That's what I thought you were talking about, but you're talking about the one that's in the PowerPoint.
No, this is a different one. This is a documentary, okay?
Okay. Thank you for the clarification.
Sorry, Jasmine. Okay, any other question?
Are the PowerPoints even on Brightspace?
They should be in Brightspace.
They have been.
They have been? Okay, maybe I'm going to the wrong place because I couldn't find last week's.
Let me know if it's not there. I will see what's going on. Okay.
What are they supposed to be like on the week?
Yes, it should be. Let me open.
Because all I see is checklist. I don't see any PowerPoint.
So I'm gonna. If you go to content, this is week number 3. Oh,
yeah, this is week 3.
Okay, I'm gonna upload that right now. Okay.
I must have been thinking for the other class, Sarah, because
yeah. For the other class, it's on there, but here I didn't see
I'm so sorry.
last week.
I get confused between two classes.
I'm gonna do that right now, so you can have it and you can see it. Okay.
Can you put are you gonna upload all the PowerPoints or just this week's?
No, I'm gonna upload all the classes. I don't know what happened here. Maybe I forgot to do it or something, but I'm gonna do it for all the classes. Okay.
Okay.
All right. So don't worry, I'm gonna do that in a moment. So you can go and have dinner and rest or watch TV or see what happened with the elections. And I'm gonna do that right now, okay?
Dr.
Thank you.
Can you also include the Zoom link for this particular class?
Yes, I'm gonna put that in the first page of the Brightspace, okay? In the announcements.
Thank you very much.
All right, so you should have the PowerPoint presentations now ready for you to download them.
Thank you. Also, thank you for, this is a lot of material. I'm shocked that this is able to be, like you were saying at the beginning, this is even able to be taught in 8 weeks.
I know.
I have no idea how. So thanks for smushing all of this.
I know, guys, it is a lot of information, and honestly, I feel bad that this is an 8 weeks class, but it is what it is. So do your part, do your readings, go and watch the documentaries. All that is going to help you a lot. Okay. Very nice to see you guys.
Bye bye.